Good morning again. I'm very honored to introduce our next speaker, Dr. Stephen Cochi. Dr. Cochi is CDC's Senior Advisor to the Director of the Global Immunization Division. Steve has over 35 years of immunization experience. In 1993, Dr. Cochi became the first director of CDC's efforts in the Global Polio Eradication Initiative. Steve has also served as the director of CDC's Global Immunization Division, the division which is responsible for all of CDC's international activities in immunization. In addition to polio, Steve has also led CDC's work in the Global Measles and Rubella Initiative. He has also been a key founder of CDC's partnership with another major polio partner, the Global Alliance for Vaccines and Immunization, commonly referred to as Gavi. Steve's public health career built on his foundation as a clinician. Before joining CDC, Steve worked as a pediatrician in the Indian Health Service in Gallup, New Mexico. Steve remains board certified in both pediatrics and preventive medicine today. Dr. Cochi's deep and broad experience in medicine and immunization have well prepared him for his talk with us today. Steve will use his perspective to show us how many facets of public health interrelate and support each other, and in particular, how the Global Polio Eradication Initiative has laid the foundation to meet future public health challenges. For example, supporting both immunization and the challenges of emerging infections such as Ebola and COVID-19. I'm very pleased to introduce Dr. Cochi to you today.
Good morning, everyone. My name is Steve Cochi from CDC, and I've been asked to give a presentation on the legacy of the Global Polio Eradication Initiative and how this legacy, which is a living legacy, can serve as a pathway for progress against COVID-19. Now, a few years ago, I put together a top 10 of the major lessons learned from Global Polio Eradication. There are many more lessons, but I'm going to focus on these top 10 lessons and how these are relevant for the COVID-19 situation that we currently are faced with, and how these lessons can be applied to making more progress against COVID-19. In fact, some of these lessons have already been applied, and I will get into this toward the end of my presentation, some of the concrete examples of this. So first of all, I'm going to go through the lessons. Lesson number 1 from the GPEI is we have learned a lot about mobilizing social and community support for vaccination. This includes reaching the underserved and marginalized groups on an unprecedented scale, tracking mobile and migrant groups and communicating while they're in transit, using traditional religious, community, and civil society leaders and structures for community mobilization. And we have, in many countries of the world, massively mobilized communities, house by house. And finally, we have reached parents at social, cultural, and religious events, including weddings, shrines, festivals, religious events. So think about how some of these aspects can be applied for the community engagement and mobilization that will be required for COVID-19 and is already being required. Now, UNICEF, among the core partners, has been in the lead on understanding communities for the partnership, working with the ministries of health and community leaders, communicating effectively with communities and parents to respond to their greatest needs, and training and motivating and empowering frontline workers. So this is how this first lesson has been implemented by GPEI. Now, lesson number 2 is we have used a targeted disease initiative as a springboard for broader health communication. And among the lessons learned in this category, we have delivered additional interventions besides oral polio vaccine. co-delivery with deworming medicines, vitamin A, bed nets, measles vaccination, and sometimes other vaccines. We've invested in interpersonal skills management and motivation of all frontline workers. We've used the occasion of supplementary immunization activities to deliver routine immunization messages. We've tracked pregnant mothers on prenatal health care and their children on immunization schedule completion from the newborn period onward. And we've built trust for oral polio vaccine in inaccessible or insecure communities through health camps. And this trust building with the community is going to be essential going forward with the delivery of COVID-19 vaccines, because we're already seeing some soft signs of vaccine hesitancy. The impact of integration, and here's just a couple of examples that I wanted to show. Using polio campaigns for co-delivery of bed nets. Example here was in Niger. Using it to deliver measles and polio vaccines simultaneously, such as in DR Congo. We've given polio drops since 1988, and the result of that is that more than 18 million cases of paralytic polio have been prevented as a result of polio vaccination. And finally, in the lower right-hand corner, we have in many countries, over 50 countries, delivered vitamin A along with polio vaccine in polio campaigns. And it's estimated that we have prevented well over 1.5 million deaths due to that otherwise would have been due to vitamin A deficiency disease. Now, lesson number 3. This is the demonstration in GPEI of the value of an advanced state-of-the-art global, regional, and national polio lab network. We've learned how to manage and finance large lab networks through the Polio Eradication Initiative, to subject the laboratories to an annual accreditation process, proficiency testing, and surveillance performance standards to ensure that we have a high quality, high performing laboratory network. We have transferred a great deal of technology through new diagnostic tools to the field. For example, preliminase chain reaction, and done research that has furthered the ability to do rapid diagnosis of polio. We have supplied labs with reagents and testing kits and specimen transport systems to return specimens in a timely way from the field back to the laboratories where the testing takes place. We have standardized data collection, compilation, and analysis, provided timely feedback with linkage of the laboratory results with the epidemiological results on each and every suspected case of polio. And here is a map graph that shows that the polio laboratory network worldwide, which consists of 145 polio laboratories, has been linked in a very real and tangible way with measles, rubella, yellow fever, Japanese encephalitis, and other disease networks, a total of more than 700 laboratories in this consolidated global, regional, and national laboratory network system. And this is now being applied to help with the diagnosis, the laboratory diagnosis of COVID-19. Lesson number 4. We have developed and implemented and learned a great deal about real-time disease surveillance for polio and response, outbreak response, and building the response capacity, improving the quality of data analysis, and improving program monitoring through that high quality data analysis. We've learned to integrate the case-based epidemiological data on each individual patient with the laboratory information, linking that together into a single record. We've learned to provide timely data on a weekly basis via a tiered national, regional, and global structure. And that weekly report is sent to hundreds and hundreds of people who are involved in the polio eradication effort. I should say thousands of people on a weekly basis by email. We have extended this model to include networks for measles, rubella, yellow fever, Japanese encephalitis, and rotavirus. We have very active measles and rubella elimination activities in all of the countries of the world. And in fact, the occurrence of COVID-19 has not only impaired the ability to move forward on polio eradication, but also has created challenges for measles and rubella eradication. We have learned to perform environmental surveillance through the polio laboratory network to supplement case-based data, and environmental surveillance, because the COVID-19 virus is shed in the stools, may become a supplementary effort that will provide some additional information to the surveillance of COVID-19 worldwide. And we have used emergency operations centers, for example, for the Ebola response in Nigeria. The Emergency Operations Center, the infrastructure for polio in Nigeria was adapted to address and terminate, to address the importation of Ebola into Nigeria and terminate that importation and that outbreak with less than 20 Ebola cases, which was a dramatic example of the central role that emergency operations centers can play in addressing outbreaks in a very timely way and terminating them. Now, the impact of integration, just a few examples shown on this slide. Using the polio surveillance and lab network in Angola, you see in the lower left-hand corner, assisting a Marburg fever outbreak investigation a number of years ago. And in the lower right-hand corner, in Nigeria, assisting with the avian flu surveillance and response several years ago when that was threatening Nigeria and the world. Now the next lesson number 5. GPEI has learned to develop and implement strategies in conflict-affected areas and address risks of international spread. International spread is the word of the day for COVID-19. So this lesson can be applied very liberally to the situation that we currently face with COVID-19. GPEI has been cited for its success in implementing strategies in conflict-affected areas, often called days of tranquility. And this goes all the way back to the mid-1980s in El Salvador and Central America during the Civil War period. Polio eradication is an example of the global public good, and GPEI has mobilized and deployed human and financial resources to protect at-risk polio-free regions and countries. We also have an example, the longest ever public health emergency of international concern, or FIC, declared by the Director General of WHO in May of 2014. And that FIC continues to be in effect up to today. The Director General created a polio emergency committee to review the global situation with polio eradication and international spread on an every 3-month basis. I serve on that polio emergency committee. So here's a photo that shows days of tranquility that are opportunities for the warring factions to have a peace treaty for a short period of time so that polio vaccine, and in this case, other vaccinations can be delivered. I believe this photo is from El Salvador in in the mid to late 1980s. And here's an example from polio of how international spread has been a great challenge for the program. International spread from Nigeria, beginning in 2003, when several northern states in Nigeria stopped vaccinating with polio vaccine because of unfounded fears that the vaccine was laced with the HIV virus, or that it was causing sterility in the children who were receiving the vaccine. And the virus spread to more than 20 countries across sub-Saharan Africa, and even distantly to Indonesia. And we have another example shown in the green arrows from India, where a transcontinental spread of poliovirus from northern India to Angola, and then from there to Namibia occurred. So these are examples from the polio eradication experience, where international spread has had to be addressed, and implementation of measures to terminate that spread have had to be implemented in a very wide geographic area. In the case of the spread from Nigeria, there were 56 importations out of the 68 events between India and Nigeria that took place over the course of 3 to 4 years. Lesson number 6, an essential need for a program of research and innovation. The GPEI has learned to recognize the constant and ongoing need to adapt and optimize strategies, to embrace research as an essential, critical part of the program, and to fast-track development, testing, and licensure of new tools like monovalent OPV, bivalent OPV, and now most recently the novel OPV type 2 that Dr. Verdefe will have told you about in his presentation earlier this morning. We have learned that operational research is a key element for success in polio eradication, and have developed special operational strategies to reach underserved and migrant populations. And here's just a couple of examples. On the left-hand side of your slide, you see vaccine vial monitors, the white and purple circles on vials of oral polio vaccine. These vial monitors are temperature sensitive and will change when the vial has been exposed to excessive heat. And I think many of you are familiar with these. You may not be aware that the oral polio vaccine vials were the very first vaccine vials where the vaccine vial monitors were tested successfully and then implemented. This goes way back to the mid-1990s. And then on the right-hand side of the slide, you see the example of going from a trivalent oral polio vaccine with the 3 serotypes of polio vaccine virus to bivalent OPV, and introducing IPV to provide some immunity against the type 2 virus, which was removed from the trivalent vaccine. This occurred in 2016. Lesson number 7. We have learned a great deal in GPEI about partnership coordination, advocacy, and resource mobilization. We have learned to coordinate across agencies our advocacy and resource mobilization activities through a very strong partnership, polio eradication partnership. We've had interagency coordination committees developed and implemented at the global, regional, and national levels in key countries. A large number and diversity of partner organizations contribute to program success, and the methods and infrastructure for tracking financial resource requirements and cash flow are highly developed in this program, which has become nearly a $1 billion per year program. And this is just an example of the budget that was created at the front end of a 6 to 7 year period from 2013 to 2019. A budget estimate of about $7 billion. And most of that, those financial resources were raised up front to allow the program to be less diverted in its energies to fundraising and focus more on program implementation. Lesson number 8, strategic planning and policy development has been a cornerstone of polio eradication. We've learned the need to have multi-year strategic plans and a planning process throughout the life of GPEI. We've elaborated national emergency action plans for the 3 remaining polio endemic countries over the last several years. Nigeria, which is now polio free, Pakistan, and Afghanistan. We have developed technical advisory groups and policy development at the global level through SAGE, the Strategic Advisory Group of Experts on Immunization at WHO headquarters, through regional technical advisory groups and national level tags in key countries. And we've had national, state, and subnational task forces in key countries to guide and implement strategy. And just here's an example of one of the, this was a 6-year strategic plan that ran from 2013 through 2018 with the 4 major objectives listed along the left-hand side of the slide. Lesson number 9, oversight and independent monitoring and evaluation have been a key part of polio eradication activities. In 2012, an independent body of respected leaders, the Independent Monitoring Board on Polio Eradication, was developed, and they have met on regular occasions, at least a couple of times a year, to independently look at what's happening with the program and provide very important recommendations and hard truths about what is and what is not being done properly to complete polio eradication. It's been an essential component of our oversight of the program. We have a strong central technical advisory body at the global level, as I mentioned, the SAGE, the WHO Executive Board, and the World Health Assembly each year provide governance and secure member state commitment to the program. We have a Global Polio Partners Group that meets twice a year with hundreds of stakeholders as a stakeholder voice for GPEI. And we have global and regional certification commissions to provide independent oversight of the certification process. So there is very extensive governance and oversight of the program, and has been for many years. And finally, lesson number 10, monitoring of program accountability and performance through the surveillance system, through other means, has been a key aspect of GPEI. It has generated national emergency action plans in a few key polio endemic countries, microplans and mapping of communities, including the use of global positioning systems, accountability frameworks created and implemented to ensure high quality management and implementation of the program, and linking accountability with objective monitoring data, such as the polio campaign coverage surveys, independent monitoring teams, lot quality assurance sampling surveys, and seroprevalence surveys. So just one example of this here is, here's an example for the three polio endemic countries in 2014, Nigeria, Pakistan, and Afghanistan. You see some of the accountability framework measures that the head of state has oversight of the program on a regular basis. There are polio control rooms or emergency operations centers at the national and in some instances state levels in the endemic areas. District and local government authority accountability and partner surge optimization. So this kind of monitoring framework was developed to improve the accountability of the program. Now, as we get toward the end of my presentation, I wanted to show some real examples of how those lessons learned through the Polio Eradication Initiative have been applied or have the potential to be applied to the COVID-19 situation in order to turn that challenge into an opportunity. Now, the Polio Oversight Board met in late March of this year. They made the following recommendations. That polio eradication country programs should prioritize the response to COVID-19 for the next 4 to 6 months. So the Polio Eradication Initiative went on notice that it was going to do everything it could to help countries in the world to address the COVID-19 pandemic. That AFP and environmental surveillance should remain a priority, and where possible, pair it with COVID-19 surveillance. And this, in fact, has been done extensively, and I will give you some more details on this in a few minutes. And finally, that activities that contradicted the global guidance on physical distance should be suspended. And that's why, for a short period of time, the polio SIAs were suspended and are now being renewed or started again as of July and August of this year. Now, since late March, WHO and UNICEF polio staff have supported the response to the pandemic. They've coordinated the response through the Emergency Operations Center platforms, polio-specific platforms in selected countries. They developed guidance documents for integrating AFP surveillance and COVID surveillance systems. They've reported suspected COVID cases during polio surveillance visits and through contact tracing. Capacity building of healthcare workers who are polio-funded healthcare workers on COVID issues has taken place. The communications have been strengthened for COVID-19 through helplines, awareness raising, managing rumors and misinformation about COVID-19. And that community engagement and outreach that I described as early in my presentation as major lessons that GPEI has learned, that has been applied to COVID-19. There's been soap distribution in SIAs, and the logistics, which are very well developed in the Polio Eradication Initiative, have been applied to COVID-19. And there are also regular GPEI updates that come out of WHO headquarters on the COVID-19 situation that have been shared with donors and stakeholders to supplement the regular information that is provided to donors on polio eradication status. So this is a very busy slide, but it gives some very concrete examples of how those lessons learned in GPEI and the polio network itself has supported COVID-19 response. I want you to focus on the right-hand side of the slide, the blue rectangular box. In 52 countries in the African region, the Eastern Mediterranean region, and the Southeast Asian region, 610 permanent polio staff and more than 3,000 temporary polio staff consultants have been applied to the COVID-19 response. And if you look on the left side of the slide, which focuses on what has been done to support the COVID-19 response in the African region. Fully 2,025 polio-funded staff have supported the COVID work in the African region in 36 countries. And you see the map on the left-hand side of the slide with the green circles showing how those staff, where those staff are located, how they are deployed, those polio-funded staff throughout sub-Saharan Africa. Now, if you go back to the right-hand side of the slide, over 60% of the polio assets are at the subnational level. And in many of these 52 countries, 50 to 80% of staff time of these polio-funded staff is currently spent on the COVID-19 response. So there is a major, huge personnel contribution that is being provided by the polio-funded staff to COVID-19 response. And the main activities, and this harkens back to some of those lessons learned that I told you about earlier. The COVID-19 surveillance, the linking of COVID-19 surveillance with polio surveillance, contact tracing, data management and analysis, community engagement and risk communications that are focused on COVID-19, transport of specimens, logistics, supplies, management and coordination, a key function in the polio eradication effort, and many lessons have been learned in polio eradication that are being applied to COVID-19. And finally, training and capacity building. So there is a wealth of lessons learned from polio eradication that are now being applied to the COVID-19 response, including the human and financial resources of polio eradication. I hope I have brought that clearly across to you, that this living legacy of polio eradication is contributing very substantially to the COVID-19 effort. So I'll conclude by saying that this integration or transition of polio assets has been very substantial for COVID-19, and we hope over the longer term it will continue to contribute to increasing immunization coverage and equity that is reaching every child, increasing country capacities to detect, report, and respond to disease outbreaks, sustaining and expanding the scope of national laboratories, and strengthening the resilience in country core capacities to prepare for responding to COVID-19 and other emergencies that may occur in the future. So thank you very much for listening, and this concludes my presentation. Thank you.